Hello dear students. Today's session is on myelodysplastic syndrome. Myelodysplastic syndrome. Myelo being bone marrow dysplasia. Dysplasia or it's an ineffective production. So myelodysplastic syndrome represents a group of clonal hematopoietic disorders with the common features of ineffective blood cell production and a tendency to progress to AML. So basically what happens in myelodysplasia is there is ineffective production of the various cell lineages like RBC, WBC and platelet. So it can affect all the three lineages or any one of the lineages and can result in ineffective blood cell production. So it is a pre-leukemic condition. It's a pre-malignant condition. Pre-leukemic and represents genetic steps in the development of leukemia. So myelodysplastic syndrome is basically a disease of older age, elderly, and there are genetic abnormalities that happen which results in the clonal hematopoiesis. So there are genetic abnormalities which have been identified and are present as a manifestation of clonal hematopoiesis in about 3% of the patients over the age of 80. So even when the patients have a normal blood count, such mutations or genetic abnormalities have been identified, and this is called the clonal hematopoiesis of indeterminate potential. So such patients may progress to leukemia. So what you have to know is myelodysplasia is ineffective hematopoiesis and it is a pre-leukemic condition. So it is ineffective blood cell production. The clinical presentation of myelodysplastic syndrome presents as they present with the consequences of bone marrow failure. So they can present with anemia if there is a low RBC count. They can present with recurrent infections if there is severe leukopenia. They can present with bleeding when the platelet count is low. It usually occurs in older age group. The median age at diagnosis is 73 years for myelodysplastic syndrome. There is a WHO classification of myelodysplastic syndrome which you would have come across in pathology as well. So WHO classifies myelodysplastic syndrome into 6 types. Myelodysplasia with single lineage, MDS with single lineage dysplasia, MDS with ringed sideroblasts, MDS with multi-lineage dysplasia, MDS with excess blasts, MDS with isolated deletion of 5q and unclassifiable. So with single lineage dysplasia, with ringed sideroblast, with multi-lineage dysplasia, with excess blasts, with isolated 5q deletion and unclassifiable. In single lineage dysplasia, there is less than 5% blasts and single lineage dysplasia only. So that is only one lineage among the RBC, WBC and platelets is affected in MDS with single lineage. But in ringed sideroblasts, there is more than 15% ringed sideroblasts in the bone marrow. So the bone marrow finding is the one which is used for classification. So there are more than 15% ringed sideroblasts or 6 to 14% ringed sideroblasts with the presence of SF3B1 gene mutation. The third one is MDS with multi-lineage dysplasia where you have less than 5% blasts and dysplasia in 2 or more lineages. First one had only dysplasia in one lineage. Here you have 2 or more lineages. The fourth one is the MDS with excess blast. So 5 to 19% blast in bone marrow. More than 20 or more, it is leukemia. It is classified as leukemia. So that's why this is called a pre-leukemic condition which can progress to AML. MDS with the deletion of 5q, associated with the deletion of 5q cytogenic abnormality, they have less than 5% blast and often normal or increased blood count. Often normal or increased blood platelet counts. So this is classified as a separate entity, the myelodysplastic syndrome with the 5q deletions. None of the above are inadequate material. They are classified as MDS unclassifiable. So there are 6 classes based on the bone marrow findings. The prognosis in myelodysplastic syndrome is a progressive worsening of dysplasia to fatal bone marrow failure because there is ineffective blood cell production. Progression to AML can occur in 30% of the cases, so such MDS patients have to be kept under close follow-up. It is a pre-leukemic condition. The time to progression varies from months to years. The slowest progressor being MDS with ring sideroblast and single lineage dysplasia, and most rapid being MDS with excess blast, which is very obvious that because about 5 to 19% blasts are seen in bone marrow in MDS with excess blast, and when it becomes more than 20%, that's when you call it as a leukemia. Now, prognostication can be done by the revised International Prognostic Scoring System IPSSR, which takes into account 3 prognostic factors for scoring. That is blast percentage in bone marrow, karyotype, and number and degree of blood cytopenias. So these are the 3 prognostic factors which is used in IPSSR. That is the blast percentage in bone marrow. We had already seen that blast percentage in bone marrow, the karyotype of the patient, and the number and degree of blood cytopenias. And based on this, they have classified myelodysplasia into 5 risk categories, which determine the survival and leukemic transformation. So they give you the risk of mortality and also leukemic transformation. And so they have been classified into 5 groups. That's very low, low, intermediate, and high and very high. So 5 risk categories have been formed based on the score of the 3 prognostic factors, and they predict the median survival and the 25% progression to AML in years. So you can see that the very high risk has a score of more than 6, and the median survival is only 8 months. Only 0.8, and the 25% progression to acute myeloid leukemia occurs in less than 1 year. So based on the blast percentage, number and degree of cytopenias, and karyotype, there are 5 risk groups that have been formed to predict the median survival and the chances of progression and the years taken for progression to AML. So management of myelodysplastic syndrome, it is incurable in majority of the patients. So it is basically supportive care because it's a pre-leukemic condition. Supportive care with red cell transfusion for anemia and platelet transfusion for thrombocytopenia when the patient presents with bleeding. And low risk MDS, that is IPSS, very low, low and intermediate. A trial of erythropoiesis stimulating agents and granulocyte colony stimulating factors GCSF and ESA may be done. Otherwise, the treatment of MDS is basically supportive. The prognosis depends on the type of MDS and the 3 prognostic factors, that is the percentage of blast, karyotype, and the lineages, the number of lineage, number and degree of cytopenias. MDS with isolated 5q deletion 5q has good response to lenalidomide. That's why it is taken as a separate group, and it has shown good response to lenalidomide. So that is the importance of karyotyping in MDS. Allogenic stem cell transplantation, that is the definite treatment, but because this happens in patients above 80 years, usually the comorbidities and the functional status of the patient prevents or rules out the possibility of a stem cell transplantation. But high risk patients with good performance status may be given the option of allogenic stem cell transplantation because, as we had seen, they have a high risk of progressing to AML in the first year, as well as a high mortality or a low median survival rate. So in patients with such high risk patients with good performance status may be tried for stem cell transplantation. Another agent which has improved survival by at least 9 months in high risk patients are the hypomethylating agent azacitidine, which has been used. It only prolongs survival, it is not a cure. So stem cell transplantation may be tried in high-risk patients with good performance status. Otherwise, the treatment of MDS is basically supportive treatment with correction of anemia, correction of thrombocytopenia, prevention of bleeding, treatment of infections, and one drug which can work in MDS with isolated dilution of 5q is lenalidomide. Thank you.